this is my next slide. So basically, how to mitigate complications and maximize outcomes post AFib ablation. So I'll get it into two parts. Number one is what complications do we have with cryoablation, and like any procedure we do, these are the 6 I can list to you. Number one is access site. We are all, I think, on this room familiar with access site complications. I think the most interest is on phrenic nerve, esophageal injury, pulmonary stenosis, strokes, and tamponades. So these are all the 6 we can experience with atrial fibrillation ablation. So I'll go through some data. As our experience with ablations has been increasing, our procedure complications have been decreasing. If you look at this slide, phrenic nerve injury was 11% around 10 years ago, and right now, Fire and Ice was a 6-year-old study. The complication rate was down to 2.7%. So with time, the incidence of phrenic nerve injury has decreased significantly. Then if you go down, you look at pulmonary vein stenosis, and that was one question asked by the panel. Right now, I never say 0, but it actually is 0. In the Fire and Ice study, there was 0 pulmonary vein stenosis reported because, as Dr. Jaisraj explained, when we ablate, we don't go into the vein, we isolate the ostium of the vein. So the risk of pulmonary vein stenosis is almost 0. But that is also true with the risk of pulmonary vein stenosis with current radiofrequency ablation is also very low. It's not 0, but it's also almost less than 1%. So groin complications, post-ablation, the groin complication, whether we do an cryoablation or a radiofrequency ablation, there are groin complications. This data from Fire and Ice showed that there were less groin complications with cryoablation versus RF ablation. In my mind, the data shows that it's less with cryo, but I don't know why it's true or not true, because with the cryoablation, we use a 14 French sheath. So intuitively, you may think that the patient will have more complications with the groin because the sheath size is bigger. But my bias on this is I think the procedure time is shorter, so the risk of groin complications is lower. Or because we have a bigger sheath, we hold pressure more carefully. I think, but there must be a bias here because there's no reason to have one procedure have more groin complications than other procedures. So I think because it's a 16 French sheath, we are a little more careful. So I think the groin complications go down. When I do cryoablation, and everybody's different, most of us end up using 3 sheaths, a right-sided 16. We use a left-sided 7 and a left-sided 9 for an ICE catheter. If you don't have an ICE catheter, then you just need a catheter to pace the phrenic nerve. The other complication we look at is cardiac tamponade. The risk of cardiac tamponade is 0.3% pericardial effusion after a cryoablation. So the risk of tamponades with an RF is a little higher because obviously it's a different energy source. Heat is obviously more potent than the freeze technique, and the risk of perforation is much lower. In 8 years, touch wood, I don't want to jinx myself, but I've had only one tamponade, and that was in 2014. And I know why I had it is because the patient had a ASD, and they always teach us not to go through an ASD to do a pulmonary vein isolation. And I was lazy that day probably. I just went through, and then when I was trying to go to the inferior vein, my catheter slipped out of the right atrium, and I think I scraped the bottom of the left atrium. The patient had a drain put in by the cardiologist right at the bedside. She did fine, but that's the only. It was a lesson to me to never go through an ASD to do a pulmonary vein isolation. Other than that, if you look at the incidence of strokes, they're pretty similar to RF or cryo, saying that the modality is safe. There are studies coming out that people who had AFib ablations, their risk of microemboli in the cerebrum, but the data, but it's very minimal, and the data is very low. The other question was esophageal ulcers and fistulas. Atrial esophageal fistulas were a big fat 0, so were the risk of pulmonary vein stenosis. What we do, so as we've learned, and the question would come, why was the risks higher before and then lower later? Because I think we have strong respect for the phrenic nerve now. I mean, when we do ablations of the right-sided pulmonary veins, we're very careful of pacing the phrenic nerve and also using adjunctive therapy like compound potentials or fetal heart rate, or using the ICE catheter to look at your phrenic nerve. And the moment we see some phrenic nerve, the amplitude of the pacing come down, we go ahead and we stop ablating. And by doing these adjunctive therapies, our phrenic nerve rates, I think now are down to almost 1% or less than 1%. But the good news is that if you break down phrenic nerve injury into three kinds, as transient and phrenic nerve injury and persistent, 99, and I'll show you data, but 99%, even if you have phrenic nerve within the time of the ablation, after 30 days, almost 90% resolve. And the few isolated ones who still have phrenic nerve injury, they resolve within a year. And we've also seen that happen. So among the 1% who do have phrenic nerve injury, almost all of them resolve. And this is also, as we are starting to do phrenic nerve pacing and adjunctive methods, if you look on the slide on the right, the extreme right, the risk of phrenic nerve pacing is almost down to, phrenic nerve injury is down to 0.5%. The way we can monitor, I mean, in the lab, I told you we put a catheter in the right superior vena, in the superior vena cava, and we pace the phrenic nerve throughout the procedure. The one thing we do is we do not give paralytics if we do general anesthesia, but if you do conscious sedation, that's not an issue. And most people, in addition to using phrenic nerve pacing, will use the CMAP technique. Well, they put an EKG and map. But I think end of the day, you can look at fluoroscopy also, see the phrenic nerves pacing. You can see the chest wall move with the pacing, but most of us use the palpation method, and that's been pretty good about decreasing phrenic nerve pacing. So most of the time, see, if you look on this fluoro, it's called the proximal seal technique, and we were doing a bunch of these. We always show that there's a leak in the right superior pulmonary vein before we go and occlude the vein, and this has helped us decrease phrenic nerve injury maximum, because the deeper you go into the pulmonary vein, the higher the risk of having phrenic nerve injury, even pulmonary stenosis. So the caveat is we never go into the pulmonary vein to ablate, we only ablate the os of the pulmonary vein. And esophageal injury is a known complication of AFib ablation. When we did radiofrequency ablation, instance of atrial esophageal fistulas were very high. I did have 2 deaths when I used to do RF from atrial esophageal fistula. Patient presented with strokes after maybe 1 or 2 months after the procedure. But what we do now is we put an esophageal temperature probe in the esophagus to monitor esophageal temperature. And if incidence of esophageal ulcerations happen if the esophageal temperature goes down to 14 degrees while we are ablating, but we usually come off when we are at 30 degrees. So if we come out at 30 degrees, we have a 2-time safety margin. And if they do go down to 25, then we send them home with a PPI for 30 days, proton, omeprazole or any drug. But incidence of esophageal injury right now also is almost 0 to minimal. And strokes and TIA, we don't stop anticoagulation in our patients. So if they come on DOAC, we leave them on DOAC. If they come on Coumadin, we maintain INR of 2 to 3. We don't stop antiarrhythmics and the anticoagulation in these patients. And when we do the procedure, we maintain an ACT of 300. How we do it, it's a stylistic approach. Some people will give half of heparin before they go transeptal, maintain half later. But since we also keep an intracardiac echo catheter, it's very easy to visualize clot. And the moment we know there's clot, we'll come out. And also, all these patients, will get a TE the day before. And with an ICE catheter, we look at the left atrial appendage to make sure there's no thrombus in them. So the risk of strokes has actually come down. And the risk of air emboli, we all know that we have to be careful with that, and we are all very careful with that. So, the patient got out of the procedure safely, and the ablation went well. And in an ideal patient, they've done great for the last year. But there are some patients, we have to also remind ourselves that, there will be other things we have to do to maintain sinus rhythm. So how do you predict success in these patients? You have procedural success. The question is, does procedural success translate into freedom from atrial fibrillation? The answer on the studies is yes, 85% of people will maintain sinus rhythm. But in people who don't maintain sinus rhythm, what else can we do, right? So the most important part of maintaining success is obvious to have a good, successful procedure. We had asked about the approach of the transeptal. We go anterior, inferior septum, because by this we can prove, initially when we did RFs, most of the leaks we saw were in the right inferior pulmonary vein, because that's the hardest to get to. And we try to be a little lower on our transeptal axis so we can get the veins isolated. So that also, the procedural success rate predicts the time of predicts success of atrial fibrillation. And the key obviously is, to use ice to make sure we isolate the veins appropriately, whether we use fluoroscopy or pressure map, or you give venograms. I do venograms in everybody because the visual perception is much better than using any adjunctive therapy. But I also use an ice catheter. I look for leaks in the vein when I do that. I also do pressure map. But at the end of the day, I've been using ice as well as a venogram to prove that there's occlusion. And this is basically an example of an occlusion. We're shooting a venogram, the right inferior pulmonary vein, and you see that the vein's not occluded because as it plays, you see there's a leak in the inferior part. But then if I push the balloon a little down, if you notice the angle, the right-sided video shows that it's more of a hockey stick. You can see that there's more occlusion. You can see the inferior vein of the right inferior also fill up, and you know that you've occluded effectively, and that will give you a great occlusion. And because of an occlusion, it will give you a much better size. The one also strategies in people who have common pulmonary veins or have 5 pulmonary veins. In the common pulmonary veins, since the vein is bigger, if the vein is greater than 32 millimeters, 28 millimeters, because the size of the balloon is 28 millimeters, then you have to do some segmental occlusion of the pulmonary veins. You will have common pulmonary, you have to go superior, you have to go on the floor. But these are just approaches we do, but we are able to achieve AFib pulmonary isolation in the common pulmonary veins also. So this is how we do it. We go up, we go down, and then we go in the middle, and we can finish isolate the vein. So there are many options. Most of us, I think, I've gone to almost 5 EP labs in India. Most of them, and everybody utilizes vein occlusion verification options differently. But I think the common fluoro is basically the common denominator here. Some use ice, some use pressure wedge, but I think most people, from what I've seen, are very comfortable with fluoroscopy. So I think if you're comfortable with fluoroscopy, do fluoroscopy. Nothing is stopping us. Our goal is not to do zero fluoroscopy, which I think will be great in an ideal world, but the goal is also to minimize our fluoroscopy for ourselves and our patients. But you can, over time, fluoroscopy reduction is a phase. I mean, when I started my fibrillation, I was taking 15 minutes of fluoro time. Now I'm down to 30 seconds to 1 minute of fluoro time because I've just kind of, eliminated certain things. But that doesn't come overnight. It comes with time, and it comes with adjunctive methods. So, but whatever modality you're comfortable to show vein occlusion, you should do that procedure. So I showed you this slide before, the proximal seal technique, and we never go into the vein. And this I use ice to show vein occlusions. I have some very nice pictures to show vein alignment. So if you do this, if you're looking at the left inferior pulmonary vein on the left side, you see that there's a leak. So what you do is you clock the balloon a little more. You can show complete occlusion and there's no leak on your intracardiac echo catheter. And the one thing is nice to see in this picture is always the 50% of the balloon is outside the pulmonary vein and 50% of the balloon is inside the pulmonary vein. So that gives us a little bit of an idea that we are not very deep or we are wedged into the pulmonary veins. We can use pressure waveform too, but a lot of us struggle with pressure waveforms. I do because a lot of times there's artifact and you can't tell when it is. But if you get used to it, it's also a great way to decrease your fluoro time. But you can use 2 modalities. You can use pressure waveform and ice, or use fluoro and ice. I think 2 modalities are enough to prove occlusion, whichever you're comfortable with. So, and then the timing of the lesion is very important, whether you give a 120-second lesion, a 180 or a 240-second lesion. That depends on this slide. It's called time to isolation slide, which is Ayush Ariana's paper. Basically, if your vein isolates in 60 seconds, then we only give a 2-minute freeze. If it isolates between 60 and 90, you give a longer freeze. And so there are different algorithms we have to decrease the amount of cryo energy delivered to the patients, and depending on when they isolate, we use these modalities. So we are trying to minimize our complications and improve our success, which is the goal of every procedure. And the clinical value, obviously, there's something called time to isolation. Once you isolate the pulmonary vein and you come off, if the time to reach 0 degrees is greater than 10 seconds, you almost have a 99% success rate of pulmonary vein isolation. And we use the Achieve catheter, which also Dr. Jaisraj already showed you this, so I don't have to show you that slide. But I'm going to stop with 2 or 3 slides. So the question is, how do you define success, right? I mean, success is a variable, it's a very variable event, but in the HRS, EHRA, and ECAS guidance basically says success of atrial fibrillation is defined as being AFib free for 36% from the date of the ablation. So three years. Most loop recorders we put in last 3 years, so that gives us good 3-year data. Now, because our AFib, I've been doing it for 8 years, we've exchanged loop recorders out in South. With the higher CHAD score patients, leave a loop recorder. We'll put a second loop recorder in these patients also. But if you have a CHAD score of 1 or 2 or 3 years is enough to prove success. And then also I talked to you about, you can monitor them with EKG, you can monitor them with a Holter monitor. We use a lot of ICMs, and then 10 to 20% of these people who have atrial fibrillation will develop tachybrady over time. They'll end up with a pacemaker. You can monitor them with a pacemaker also. And just because we finished the ablation, our story is not done, right? I mean, we've been talking about atrial fibrillation, sleep apnea, and obesity as independent risk factors. If an obese patient loses 10% of his body weight, the risk of AFib post-ablation decreases by tenfold. If the patient's sleep apnea is controlled, the patient's AFib decreased tenfold. Just because, when we talk about Dr. Roshan's patient, if in 2005 they did not have sleep apnea, they can develop sleep apnea over time, which can increase your AFib recurrence also. So we have to be careful and vigilant about, the independent risk factors over time, because this is a disease we deal with 15 to 20 years. So we have to keep looking at, their atrial, looking at obesity, looking at their, risk factors, looking at lifestyle modifications, looking at sleep apnea. It's not a snapshot in time. It's an evolving disease. And if you look at sleep apnea and atrial fibrillation treatment, this basically shows that sleep apnea is independently associated with atrial ablation failure, But if you treat them with CPAP, they have a higher ablation success rate. The left atrial diameter, I think we talked about in great detail. The left atrial diameter predicts success rate in atrial fibrillation as an independent marker. But we don't use it to refuse or not do atrial fibrillation. This is just one more adjunct we use to define, to look at success. Metabolic syndrome, kidney damage, hypertension, these are all independent risk factors. And unfortunately what has happened for us is with atrial fibrillation, electrophysiologists have become the primary cares for atrial fibrillation. Right now, atrial fibrillation management has become so complex to a fault that anytime a patient comes to the hospital, like I told you, we're getting consulted for atrial fibrillation directly from primary care physicians and also from cardiologists. So 2012 or 2014 in my office clinic, if I saw 50 patients a day, around 40 patients would be for SVTs, for device therapy, for device management. 5 or 6 would be for atrial fibrillation. Now I see 50 patients in my office. 25 of them are for atrial fibrillation and 25 of them are for device management. So our AFib, in treatment of AFib, we are seeing more and more people with AFib, and as awareness is growing, success rate is growing, we are seeing more and more people with atrial fibrillation at clinics. And the one thing now, if you talk what's next, we are seeing more and more people come to the office asking for Watchman devices. So it's as technology comes, evolution of your practice evolves over time, and we are seeing a lot more people for left atrial appendage occlusion, which is a whole different patient population that we do. And my group, we are doing almost 200 to 250 Watchmans a year also now. So as AFib is growing, now Watchmans are also growing. And the studies are going to come out on that in the future also, if we need NOACs versus Watchmans. Then we talk about heart failure. Castle AF study came out that people who have atrial, even if Dr. Jaisraj had said people have atrial fibrillation and heart failure secondary to atrial fibrillation, but even if people, like a patient who has a BIVICD, right, keeps coming back to the hospital with atrial fibrillation, RVR with heart failure. Doing an atrial fibrillation, before I would do an AV junctional ablation on these patients and maintain the heart failure. Now if I do a cryopulmonary isolation and maintain sinus, they are doing equally well or even better. If you look at the data, it says people do much better in an AF ablation in people who have low ejection fractions. So but you're not offering to them as first line, and these people, most of them are already on amiodarone therapy or Ticosin or Sotalol, and then an AFib ablation in addition to management. So initially we used AFib ablation for tertiary management, secondary, primary. So at any stage of your AFib ablation, a pulmonary isolation can be offered to you. But it just depends on whether we use medications or not. But the goal of an ablation is to maintain sinus. Anticoagulation, we already talked. It all depends on CHRS score. We don't. Maintenance of sinus rhythm does not correlate with stroke reduction. Always depends on your CHRS score, because I think all of us understand that the inflammatory process that causes atrial fibrillation also causes strokes. So but AFib does not cause strokes. There's something else that's causing the strokes as well as atrial fibrillation. So these are the things we use to mitigate our risks, but also improve success rate. There are a lot of other risks. We send people to bariatric surgery. There will be people who will need cardioversion in the future, but I think before we would do AV junction ablation, a lot of these patients, the goal is to keep away from doing an atrial fibrillation ablation. Now, if you're 90 years of age and you're in atrial fibrillation, am I going to do AFib ablation? Probably not. Then rate control. At that point, I would not do an atrial fibrillation ablation. But at that point, if you have pacemaker, I would consider an AV junctional ablation in these patients. But and if you have 80 years old and it's paroxysmal atrial fibrillation, I would consider pulmonary isolation. But if 80 and you have moderate to severe MR, I would then try medical therapy. So everything is designed, end of the day, common sense is common sense. You have to see if I do a procedure on a patient, what success I can achieve. And if I can give them a 70 to 80% chance of success, then I would do a procedure. And also, I've noticed with patients, it's how you tell the patient. Right? If you tell the patient, look, I think you'll do well from an atrial fibrillation ablation, they'll say, yeah, I want one. But if I tell them, look, if I take you for an ablation, I can only maintain sinus for you 50% of the time. Would you want any surgery that only works 50-50? They'll say, no, I don't want it. So it all depends on how we approach the patient too. So a lot of patients will come and say, there's a 78-year-old PCP who is in my practice, and she sends me emails every day. She's arguing about getting an AFib ablation. She's on 50 BRE of flecainide for the last 15 years. She's at 3 event monitors in 12 months, which have all showed 0% AFib. She wants an AFib ablation. So I said, no, there's no reason to do it. You're 78, you're 110 pounds, you're 55 kilos, you're doing fine. So she called 4 different centers. Finally, she found one doctor who'll do a PVI, and she emailed me saying that she's very upset with me. I said, please go, but at a 78-year-old lady on 50 BRE of flecainide who's in sinus on 3 monitors, there's no reason to do an AFib ablation on this person. But if she wants it, she'll get it done, but she'll come back with some, there's going to be some issue, So she did a teleconsult and she's going to go, but that's fine, go. But these patients don't need an AFib ablation. You're doing fine for 14 years you've been in sinus. What am I going to do to make you feel better? And as physicians, I think all of us what we want to do is we want to make people feel better. If there's something that I can't make you feel better, then there's no point doing it. I'll stop there. Thank you very much.